Hi, my name is Dr. Doeun Lee. I am a board-certified endocrinologist with 25 years of clinical experience. A subsequent video to my first osteoporosis topic, today I do want to talk about osteoporosis pharmaceutical agents. There is so much information about this topic and so much confusion. Primary care physicians are overwhelmed with information. They don't know which agents to choose from when the patients really need a little bit of lifting in order to reduce risk of fracture. We do want to improve bone density non-pharmaceutical way, such as calcium and vitamin D, as well as exercise. However, when bone density is severely low, minus less than 2.5, less than minus 2.5 or 3, or you have history of fracture, which puts you at really great risk of having another fracture, more so than bone density itself, your previous fracture risk is the most important risk for subsequent fracture. Then you are going to talk about medication with your provider, and which one to choose can be really confusing. So I am going to clarify all that confusion. And if you do have other questions, please comment below. I will be able to answer that individually. So osteoporosis medication, it divided into two groups. So there is bone breakdown process and there's a bone building process. And bone seemingly doesn't appear to be moving, but at a cellular level, it constantly breaks down and it constantly builds up. Bone density is reached peak bone mass at age about 30, and you constantly diminish and after menopausal transition and with aging for male, with decrease in testosterone level and other hormonal changes, your bone density is going to continue to go down slowly. Bone breakdown process is called bone resorption. Bone building process is called bone formation. So there are two groups of medication. If you slow down the bone breakdown, bone resorption, it's going to increase your bone density. As you can imagine, you're negating the minus. Therefore, you're going to end up with positive. Bone formation medication is going to directly increase bone building cells, and then you end up getting high bone density. So there are two classes. One is antiresorptive, meaning negating the negatives, end up getting positive, and then stimulating plus. It's called anabolic therapy. So we have antiresorptive therapy and there's anabolic therapy. Antiresorptive therapy, we have many medications under this category. You may have heard of Fosamax. Generic name is alendronate. And Boniva, ibandronate, Reclast, zoledronic acid, Actonel, risedronate. So it can be oral medication, intravenous medication. Specifically, I do not use Boniva because it does not have anti-fracture data in non-vertebral area. When you take the medication for the bone density, you do want to prevent, or you want to take the medication that's proven to reduce non-vertebral fracture as well. And there's no reason to take ibandronate, in my opinion. I see ibandronate keeps popping up in my consults, and usually I do discontinue that medication. So usually I will prescribe Fosamax, Actonel, or Reclast infusion. So that's one category called bisphosphonate. And another anti-resorptive therapy is called raloxifene, which is SERM, selective estrogen receptor modulator, which is acting for the bone anabolically. I mean, similarly to estrogen, but like anti-estrogen in the breast tissue. So it does decrease risk of breast cancer in high-risk individual, but then also it increases bone density in the spine. Like Boniva, STARM does not reduce non-vertebral risk fracture. Therefore, usually I don't select this agent. Also, it does increase hot flash, and also it does have a warning for blood clots because it's oral estrogen, which has been associated with blood clots. Another category of the medication under this category is very potent denosumab. Brand name is Prolia. People call it Prolia or Prolia, but we call it Prolia. So please change your syllable of the stress. It's Prolia. So Prolia medication is given once every 6 months. Patients really like the schedule. It is a great medication. Typically, when your bone density doesn't go up as much with bisphosphonate, when you convert to denosumab, Prolia, your bone density will likely to go up. Problem with Prolia is that you really cannot just discontinue at will, because if you do discontinue, there is a phenomenon called spontaneous vertebral fracture upon discontinuation after about 2 dosage. So if you stop it without any plan, that can be detrimental to the bone, which was supposed to help you, but then when you stop it, it's going to accelerate bone loss. Therefore, if you are considering stopping Prolia, you need to be sequentially treated with bisphosphonate or something different. You need to discuss with your physician about the transition. Prolia typically is given every 6 months. As I said, it does give you very nice bone density increase because it is more potent antiresorptive therapy than Fosamax, let's say. The duration of therapy for Fosamax is usually about 3 to 5 years, after which I evaluate the patients again, whether they did break the bone or if their T-score is, over minus 2.5. If it is good, meaning your patients did not break, you didn't break any bones, and your bone density has gone up, then usually we do a bisphosphonate holiday. There's no Prolia holiday, like I told you. Prolia should not be stopped at will. So there will be no quote for Prolia holiday, but we do talk about bisphosphonate holiday. Because when you do go off of medication, fracture prevention efficacy seems to remain in continuing to exert its effects, even though you don't take the medication. So instead of taking medication long term, really, having plateaued your bone density increase after about 3 to 5 years, no more bone density may be gained, but also you're increasing the risk of having side effects by long-term exposure. Usually we do limit our medication to 3 to 5 years. If you remain high risk of fracture, you may stay on the medication, but also you may change to different medication. So that's the nutshell of antiresorptive therapy. Bisphosphonate, there is a SERM, there is denosumab. Next category, which I am much more excited about, is anabolic therapy, which primary care physicians usually do not have a lot of exposures and do not really prescribe these agents to patients a lot. So when they need this medication because they are breaking on antiresorptive therapy, or patients just want consultation from endocrinologists, we do talk about anabolic therapy. I do want to talk about the sequence of therapy, why it's very important, later after I discuss anabolic therapy first. So anabolic therapy, first medication that was approved in this category was Forteo, teriparatide. It's given once daily injection at home, and it does increase bone density quite rapidly, and it builds bone. It really boosts bone forming property, and it does increase a little bit of bone resorption, but it increases bone formation more, so you end up with more bone. Very similar medication to that is abaloparatide. The brand name is called Tymlos, which is also given once daily. The difference between the two is just obviously the molecular structure is different. Abaloparatide is newer agent, and it doesn't have to be kept in the fridge. That's the main difference patients feel. And so it is more convenient. It's slightly stronger, more effective medication than Forteo. However, people do have a little bit more side effects with Tymlos. But some people don't have any side effects. Some people have minimal side effects. And so I tend to use abaloparatide, Tymlos, a lot. So this is another anabolic agent that does increase your bone density significantly in a very short term. But a lot of patients do feel injecting medication at home daily just doesn't sound very appealing. So then there's a very, very new kid in the block called romosozumab, which is another, brand name is called Evenity. So Evenity is given once a month at the clinic, and you get 12 treatments. And after 12 treatments, you do move over to another medication. So anabolic therapy, while it does improve your bone density in a short run, after you stop it, if you don't sequentially move over to antiresorptive therapy, you lose the bone density you gain after hard work pretty much within 1 to 3 years. So if you're not going to do antiresorptive therapy at all, no point of going with anabolic therapy, if that makes sense to you. So if you do anabolic therapy, always have to be followed by antiresorptive therapy. What I meant by order, our medical practice is pretty much limited by insurance. Insurance really tends to dictate as to how we practice. So we, a lot of times, treat patients with antiresorptive therapy first, and then your bone density doesn't go up as much, and then you break the bone, you break bones, or you're just not responding. Assuming we did all the workup for secondary osteoporosis workup, and we didn't really have celiac disease, you didn't have Cushing syndrome, you don't have any growth hormone deficiency, things like that, then, we usually go over anabolic therapy. However, when you look at the data, when you are treated with anabolic therapy first, and then you went to antiresorptive therapy versus if you did start with antiresorptive therapy and then moved over to anabolic therapy, even though you took the same medication, same duration, but switching the order, your bone density gain is so much more if you did do anabolic therapy first. So if insurance didn't dictate our lives, then I would have always chosen anabolic therapy first, then antiresorptive therapy, especially if you're at high risk of having fracture. Let's say your bone density is really low, then I would, do anabolic therapy first. So in summary, we've got two different classes of medication, antiresorptive therapy and then anabolic therapy. And antiresorptive therapy, you've got Fosamax, Actonel, reclassed, and then SERM, such as raloxifene. And there is another medication called Prolia, denosumab, which is given every 6 months, which cannot be stopped. And then there is Forteo, and then Tymlos and Evenity. So side effects of antiresorptive therapy are shared by pretty much all medications except for SERM. SERM is a very different molecule from Prolia or reclassed or Fosamax. So bisphosphonate, such as Fosamax, reclassed, and Actonel and Prolia, denosumab, share very common side effects, which is osteonecrosis of jaw after tooth extraction or implant, and atypical femur fracture. So in medicine, when we choose to use medication, we always have to analyze your benefit risk ratio. If your bone density is so low that you're likely to have fracture unless you get treated, that's when we use pharmaceutical. Because we think that your risk of having that rare side effect is way, way less than your risk of having fracture. In fact, femur fracture, atypical femur fracture that happens is very associated with a very prolonged exposure of bisphosphonate or Prolia. And it typically happens in Asian population. And it is still exceedingly rare. So the data show that if we prevent about 66 femur fracture using bisphosphonate, there is about 1 atypical femur fracture incidence. It's 1 in 66. Femur fracture is extremely rare, but happens a lot. I see patients with femur fracture because of what I do. But again, atypical femur fracture is very, very uncommon. In my 25 years of history, I do have one patient with atypical femur fracture, and she was exposed to alendronate for about 15 years before I saw her, and she developed it while she was taking Fosamax. Osteonecrosis of jaw is also exceedingly rare, is associated with risk factors. Risk factors include smoking, drinking alcohol, chemotherapy, previous radiation therapy history, and steroid exposure, things like that. If you don't have those risks, having osteonecrosis of jaw is exceedingly rare. I had one patient who developed osteonecrosis of jaw while she was taking Prolia, but also she developed polymyalgia rheumatica at the same time. So she had to take really high dose of prednisone. Therefore, she was kind of a setup for that. Very, very rarely we do see osteonecrosis of jaw without having risk factors, but that is much more rare. And then the other component of the anabolic therapy, Tymlos, Forteo, and romosozumab, Evenity, side effects are uncommon. There is really, especially the daily injection of Forteo and Tymlos, they do not share the osteonecrosis of jaw warning or atypical femur fracture warning at all. Whereas Evenity, which is both anabolic and antiresorptive, which I forgot to mention, Evenity has both qualities, and Evenity has that as warning as well. Evenity is usually really well tolerated, but when they compared Evenity to Fosamax, they saw increase in cardiovascular disease by about two-folds. So let's say 20 patients in Evenity group developed cardiovascular disease in terms of stroke and heart attack. In Fosamax group, about only 10 people developed it. And they did study further. They compared it to placebo and they compared Evenity to Forteo. When they did these studies, they did not see any increase in cardiovascular incidences. Therefore, FDA approved this medication with warning in that we should exercise caution if we're dealing with patients who have osteoporosis but had heart attack or stroke within a year. So that's my take on. Important thing to take away from this talk is really the sequence matters. I do really believe in anabolic therapy first, followed by antiresorptive therapy. And also, if you did break, we really want to have fracture efficacy, anti-fracture efficacy early on in the course. And so in that case, I do propose anabolic therapy. In general, I tend to use a lot of anabolic therapy because that's what I believe in. But a lot of times it's the sequence that I end up not doing because patients that come to my office, they're already on antiresorptive therapy. So that's the summary of osteoporosis. Pretty much everything that you need to know, but there's other more complex things, combination therapy, other sequential therapy, after this medication, what medication comes after, things like that might be a little bit out of scope of this YouTube channel video. So I will preserve for other occasions, but this is basically summary. If you have any questions or comments, please comment below. And thank you for watching for this 19-minute video.